All right, we're going to get started. Thank you for those who are trickling in. So I want to welcome you to just updates from CTOS. CTOS stands for Connective Tissue Oncology Society. It's a conference that takes place every year for the sarcoma community. So during this seminar, all participants will be in a listen-only mode, and there will be a question and answer session at the end of the presentation using questions submitted through the Q&A feature. Please remember the information provided in this web seminar is not intended as a substitute for your physician's guidance and care. My name is Sarah Rothschild, the Executive Director of the LifeRaf Group, and I would like to introduce our presenter for today. Dr. Herbert Loong holds conjoint appointments of Clinical Associate Professor in the Department of Clinical Oncology and Deputy Medical Director of the Phase 1 Clinical Trial Center of the Chinese University of Hong Kong. He is also the current and confounding convener of the Prince of Wales Hospital Adult Sarcoma Multidisciplinary Team, and he obtained his medical degree with a distinction in surgery from the University of Hong Kong in 2003. He's a recipient of the European Cancer Congress Fellowship Grant, the American Society of Clinical Oncology Annual Meeting Merit Award, and the Hong Kong College of Physicians Young Investigators Award. But most importantly, he's a good friend of the LifeRaf Group, and he's been so generous with his time to do these presentations for us. So I hope you all enjoy, and I'm going to let him take it from here.
Thanks very much, Sarah, for a very kind introduction, and good morning, good evening, everybody. Let me share my screen first, and then I'll give a brief introduction as well. Okay. And then... Okay, I think everybody should be able to see my screen. So yes, let me start again. Good morning, good evening, everybody. I'm Herbert Loong from the Chinese University of Hong Kong, and it's always a great opportunity for me to share some of the latest abstracts at various conferences to the GIST community through the LifeRaf Group. And I'm very grateful for their repeated invitations, and I actually really enjoy doing these because in a way it allows me to also look at the data a bit more in preparation for these talks. So, you would also understand that it is an ever-evolving field in terms of the things that are being researched on and also being published at various conferences as well as presentations. So in the next 20 to 30 minutes, I will talk about some of the abstracts that were presented in relation to GIST at the most recent CTOS meeting that was held in Dublin earlier this month in the first couple of days in November. And these are my disclosures. A bit of a disclaimer, I'll be using some slides that belong to the original authors and CTOS, and these are used by courtesy for this specific academic and patients educational event. The choice of to discuss the abstracts were made by my own, and certainly I feel that these are of good academic merit and impact to the GIST community. There are certainly other very good abstracts that were presented at CTOS, and if there are interests in the other abstracts, we could see whether or not we could have another session to talk about some of the other ones as well. I'm actually currently a board member of CTOS, and what I'm presenting here do not reflect the views of the CTOS board. And again, it's really with some discussion between ourselves, as well as the LifeRaf Group, as well as the patient community in terms of which particular abstracts we're discussing, as well as any of the Q&As that follow. So Sarah's already introduced the CTOS meeting, but maybe a quick word about the CTOS meeting. Not everybody may know about this meeting. You may have definitely heard of the bigger meetings, including ASCO and ESMO. CTOS is specifically an academic meeting for sarcoma specialists, and this spans from early bench research to clinical research, as well as patient advocates. And it's an ever-growing meeting. It started off with a meeting with just 50 people some 25 years ago, but now we're close to 1,800 attendees that attended this meeting in Dublin earlier this month. This was the second face-to-face meeting that we've had since the pandemic, and we're increasing the numbers of attendees. And specifically, we always have a dedicated session on GIST. There are poster sessions where some of the abstracts are also presented and good discussions with the presenters. And this year, we actually had a new trials in progress oral session where some of the clinical trials which are currently running around the world are being presented by their lead authors to introduce the community on what is actually happening. None of the results are necessarily presented at this time, but I think it's good for the international community to know what's going on in terms of research and what to look out for in upcoming meetings. So in terms of the key abstracts that I've chosen for presentation for today, there are four. The first abstract is a phase 1 study of IDRX42 in patients with advanced GIST, which are resistant to prior therapy, and the early results was presented by Dr. Patrick Shofsky. This was done in the format of a poster, but certainly we actually had some discussions during the meeting as well. Other abstract I'll be presenting here would be the INSIGHT trial. You may be familiar with that already. This is a phase 3 randomized trial of an open label study of ripretinib versus sunitinib in patients with advanced GIST, which was previously treated with imatinib, specifically in patients who have KIT exon 11 plus the resistant 17/18 mutations. Now, this is a trials in progress poster, and what that means is the study design as well as the rationale were presented and shared and discussed, but the results are actually not readily available at this juncture. So I think we may not necessarily have the results, but it's a good segue to look at the study design as well as, again, making the community aware of what research is going on. And to complement that, the group in Miami have presented their trial in progress of a trial looking at the use of ctDNA to guide the treatment between sunitinib and regorafenib. And lastly, I'll also be presenting the study design of the PEAK study, which is a randomized phase 3 study, which looks at bezuclastinib and sunitinib in combination with sunitinib in patients with GISTs. This was presented by Dr. Somaya from MD Anderson at the meeting, but certainly there were other authors there as well. And again, a good discussion about the study design and where the field is heading to. Now, I'll talk about the PEAK study first. And as mentioned previously, Dr. Patrick Shofsky presented this as a poster, and this is actually a poster in very small format, just to highlight to you how this data was being presented. And the great thing about posters is you're able to interact with the presenter in real time when you walk up to them and have very good discussions, which sometimes actually is more difficult if it's actually a podium presentation. So a bit of background about IDRX42, and these were slides that I presented last year at this particular meeting as well, when the authors of this abstract also presented their study design. This is the phase 1 study of this compound, and IDRX42 is an ATP competitive type 2 inhibitor of the receptor tyrosine kinase KIT. And what that really means is, in actual fact, it's a new tyrosine kinase inhibitor, an oral TKI, which has broad coverage in the different mutations that we see in GIST in the KIT domain, including exon 11, exon 13, exon 14, and most of the exon 17 mutations. So you may be aware of the fact that the reason why we see resistance after treatment with the various lines of TKIs is there's a generation of these resistant clones, which the original tyrosine kinase inhibitors may not be able to suppress. Well, this is essentially a new compound which has a broad coverage. And I guess the aim really is to make sure that we are able to hit all the predicted resistant clones of the tumors. So hopefully it would increase the efficacy of treatment as well as the duration of treatment in patients. Now, this is a phase 1 clinical trial, though. Specifically, we were at that time looking at the safety profile of this particular compound, testing it first in patients first, really noting whether or not it causes any particular side effects, and also to find the optimal dose for us to investigate further in the clinical space. So this was presented in CTOS 2022 by Dr. Suzanne George, together with some of the other authors who you may know, including Dr. Dimitri, as well as Dr. Shofsky. And at that time, they presented the scheme of the particular study, where the trial would start off with a lower dose first, and then to escalate the dose in the dose escalation phase. After a good dose is confirmed, the plan is to then go on to testing it in various groups of patients dependent on their characteristics, on whether or not they've had first-line treatment of imatinib, or maybe they've had other lines treatments, including imatinib and sunitinib, and really just to see whether or not there is good efficacy in the different groups of patients. Now, specifically for CTOS 2023, the dose escalation portion of this clinical trial was actually presented. And just as a reminder, for patients who are entered into this trial, these are patients who are of adult age, of course, known history of GIST. And in the phase 1 dose escalation patients, these actually required to be patients who had documented progression on at least one line of treatment, which is imatinib. They had to have good performance status and at least what we call one measurable lesion, where we could monitor the size of the tumors during the course of treatment. For this presentation, it included 33 patients. The 33 initial patients were recruited into this trial. The median duration of treatment was 16 weeks. And in actual fact, during the time of presentation, 23 patients or 70% of the patients remained on study. Now, the patients who were recruited into this clinical trial are patients who've gone through various lines of therapy. The median number of lines of prior therapy was 4. And actually, 70% of the patients had KIT exon 11 mutations, and 33% had KIT exon 9 mutations. If you remember the diagram that I showed you earlier, where they were increasing the dose to test in different patients, the 4 level of the doses were actually cleared, and up to about 600 milligrams. And in actual fact, they were also testing the 800 milligram cohort as well. On the right here is the table showing the patient characteristics, essentially showing you the different types of patients, be it males or females, the number of lines of treatments, the years of diagnosis, really just to highlight to you that there's a broad group of patients who have been recruited into this trial. Most of the trial patients, again, have been patients who've had multiple treatments before and have had the diagnosis of a GIST for quite a few years. Now, this is a waterfall plot, which actually shows how the tumor sizes have changed since the start of treatment of all the patients, all the 33 patients that were included in this analysis. The way you read the plot is that if the bars go up, it means that since starting the treatment, the tumors have grown bigger in size. But if the bars are going down, it means that the size of the tumors have gone smaller. And this is what we call a very impressive waterfall plot, where you see that most of the patients who have been entered into this trial had shrinkage of their tumors. As you can see, most of the bars are pointing down. The different colors of the bars represent the different doses of the drugs that patients were assigned on. And you can also see that there is quite a broad range of doses, which leads to shrinkage of the tumors. Although it does seem as though a higher dose may be associated with better response, you could see more of these colors here are of the higher dose range. And out of all the patients, 28 of the 33 patients who have entered into the trial were evaluable for response. So they're at a time when you can actually look at whether or not they're responding. And what they have determined is that the clinical benefit rate, so that's the number of patients who actually had some shrinkage, a partial response, or a durable stable disease for over 16 weeks, and that was about 68% of the patients who entered into this trial. And again, if you look at the x-axis here, which actually looks at the different KIT mutations, the numbers here represent the exons. So, for example, this is a patient with an exon 11 mutation, and T meaning the fact that this mutation is determined based on a tissue test. And there are some patients who actually have Cs or CTs, which means that their mutations in their tumors were determined by a liquid biopsy. And we'll talk about liquid biopsies a little later. So really, again, to impress upon you that the efficacy of this compound was seen across the board in the various types of KIT exon mutations, including the typical resistant mutations of 13, 17, and 18. Now, this is what we call a spider plot, and this essentially shows each individual patient based on the different lines. And as you go along the graph, you can actually trace whether or not the tumors were shrinking and whether or not they were increasing in size throughout the time of treatment. So, for example, in this particular patient where the line is blue, initially for the first couple of weeks, there was some growth in the tumors, and then it shrunk and it continued to shrink. And the length of these lines also give you an impression of how long the patients are on treatment. And what you can see is the majority of the patients actually had shrinkages in their tumors after starting treatment. And most of these lines do continue for a long period of time within this range, showing the fact that this ability to control the size of the tumors can be prolonged over a long period of time. On the right here, this is what we call a swimmer's plot. And again, a very similar results being presented. These ones with the arrows here are indicating individual patients who are continuing on treatment at the time of the analysis of this data. And you can see that most of the patients are continuing on treatment Again, this gives you a bit of a indirect representation of the fact that these drugs or the drug itself is well tolerated by patients because they can continue it for a long period of time. And there's also some element of improved efficacy in terms of the treatment of the disease. Now, for any early phase clinical trials, and of course, for any drugs, we also very importantly look at the safety profile. And this is a small number of patients who have initially been tested. This is a first in human trial, so we're still gathering this data as we speak. But it does seem as though the most common side effects that were seen by the patients in the trial were diarrhea, of which over 70% of patients actually did complain of diarrhea, as well as nausea and vomiting. Now, at the different doses of drugs that were assigned to the patients, you can see that as we increase the dose that were treated, there were increase in the number of patients who actually had diarrhea. Again, be very mindful of the fact that these are very small numbers of patients. So only 3 patients at this dose, only 3 patients at this dose, but 2 of them actually had diarrhea. So this does seem to be a common side effect. We also look at the grade of the side effect, and a grade 3 diarrhea is when the diarrhea is very severe. It requires you to be potentially hospitalized. You do require, say, some fluid replacement through the IV. And the number of patients who actually had grade 3 diarrhea were not all that common in the lower doses, and 1 patient in the 600 milligram cohort. So we're still generating this data, again, as the trial is progressing, but it does seem as though diarrhea is a common side effect. So just a quick summary, my take on this particular trial, I presented this slide actually last year at this very same meeting when the trial was being presented before it started human testing. And the take-home message at that time was this is a new drug in GIST, and it's a pan-KIT activity, and we should be watching the data as it comes out in upcoming conferences and meetings. And 1 year down the line, we now finally have some early data of this particular trial being presented. There is emerging evidence now in the clinical space. Diarrhea seems to be the most common side effect. I think we do need to continue this trial to find the optimal dose for testing, and then to see whether or not in the different patient cohorts, based on their prior treatments, their resistance mechanisms, to confirm the efficacy of this drug in future situations. So I'm quite sure this particular trial will be presented in upcoming meetings as well. We have upcoming meetings such as ASCO in June. We have ESMO coming in October next year. And I think that will be a space and time when we'll see more data from this particular trial. So watch out for this particular compound. So the second trial I would like to highlight, and this is a trial in progress poster, is the INSIGHT trial. And I think that's actually quite familiar to the GIST community. Dr. Sebastian Bauer was the presenter at this particular meeting for this particular trial, which again looks at the use of ripretinib versus sunitinib in patients who have KIT exon 11, as well as the presence of 17/18 mutations in their tumors. By way of background, you will know that there was previously a head-to-head comparison in the INTRIGUE trial, which was the phase 3 trial looking at ripretinib versus sunitinib in the second-line setting. The primary endpoint of that trial was looking at progression-free survival, which was not met. But however, during the particular trial, ripretinib demonstrated a comparable efficacy and a more favorable safety profile, as well as patients actually felt that the quality of life was better whilst on ripretinib versus sunitinib. You would recall that this was the survival results where essentially the patients, the way that the drugs managed to control the tumors were the same in terms of the number of patients who benefited and whether or not the disease would progress whilst on treatment. On the right here actually showed that certainly there were much more patients in the sunitinib group experiencing side effects, including evidence of, say, high blood pressure, neutrophil count decreases, as well as some skin changes as well. Now, as they were looking at the results more closely for that particular trial, what they've realized is in the patients who have KIT exon 11 plus 17/18 resistant mutations, it was quite clear that in the patient groups that were recruited into the trial, none of the patients of that particular characteristic who were assigned to the sunitinib treatment had an objective response. You could see that most of the patients who were entered into the trial when assigned to sunitinib had growths in their tumors. Whereas if they were assigned to ripretinib, in actual fact, 44.4% of the patients had what we call an objective response, and that is a shrinkage of the tumors by at least 30% of their sizes. And there were also portions of patients who actually had some shrinkage but did not meet that criteria. So the feeling is if you have this particular characteristic of KIT exon 11 plus the presence of 17/18 activation loop mutations, you may be a subgroup that would benefit from ripretinib. And the reason why the results were not positive in the main trial was this result was diluted by patients who did not actually have this particular characteristic. So this brought the investigators to design a new trial known as the INSIGHT study, which is a ongoing phase 3 randomized global trial involving a lot of study sites around the world, specifically now looking at patients who have KIT exon 11 plus the presence of 17/18 mutations as confirmed by ctDNA. So this is by a liquid biopsy and not through a biopsy of the tissue. And this is a randomized 2-to-1 study between either patients assigned to the use of ripretinib or sunitinib, and patients who actually progress on the sunitinib group are allowed to cross over to the use of ripretinib. Now, as this was a trial in progress post presentation, none of the results are being discussed. And in actual fact, I believe the recruitment of the clinical trial is still ongoing. But what we can see is that hopefully we can confirm through this trial the perceived efficacy of ripretinib over sunitinib in this particular population. And I think more importantly, it allows us to consolidate the use of ctDNA testing in GIST, because if we're able to distinguish patients who benefit from particular treatments based on the use of ctDNA, it also confirms the position of this particular technology in terms of diagnostic workup for patients. And a little background about ctDNA, it's all the buzzword now in the last 1 or 2 years in various cancer fields, of course, including GIST, but also having a big impact in lung cancer as well as colorectal cancer. When we talk about ctDNA, we're talking about essentially using a liquid biopsy, which is essentially using your blood. It can also be actually from tissue, from urine, as well as from your cranial spinal fluid, but typically we actually use blood. Now, a bit of background first in terms of tissue tumor testing. Or tissue testing is where we're looking at getting a biopsy from the actual tumor itself. Now, that would require actually a procedure for you to take some of the tissue. And some of the situations, especially in treatments of GIST, for example, is we know that as the disease progresses, they become relatively heterogeneous. And you have multiple tumors which may express different genetic codes. And if you do a biopsy, you really can only take one sample and may not be representative of the entire situation. If you use ctDNA, it's actually the tumor DNA that's being leaked out into the bloodstream, and there's a good chance that you'll be able to catch this heterogeneity. And it's less invasive, certainly. And the great thing is you could do it repeatedly over a period of time to see whether or not patients are responding to your treatment before you actually do, say, some radiology testing. And as I mentioned previously, ctDNA is being used in a variety of situations in various tumors. We could use it to molecularly profile, essentially to identify whether or not there are particular mutations in the tumors of the patients. We do that readily for patients, for example, looking for the KIT mutations. As you're treating patients throughout a period of time, the levels of the ctDNA can give you a representation of whether or not the disease is responding to your treatment. We're moving towards using ctDNA for early cancer detection. So essentially as a screening, looking at potential tumor DNA in the blood in patients who are otherwise asymptomatic. And of course, also the detection of what we call minimal residual disease, where patients, say after surgery, can be monitored over a period of time to detect whether or not there's a chance of a recurrence. So one of the other abstracts that were presented specifically in the ctDNA space which is also a trial in progress presentation, was by the Miami group, including Dr. Bialik, as well as Dr. Jonathan Trench, who, again, I think the LifeRap group is very well familiar with, about one of the studies they're conducting at the University of Miami Sylvester Comprehensive Cancer Center, looking at using this ctDNA technology in patients to help decide whether or not the patient should choose one treatment over another. And this is in the case of second-line setting of sunitinib versus regorafenib. Now, this is what we call a investigator-initiated study. It's a very small-scale study, but in probably one or even maybe one or two institutions. But the main aim really is to look at the scientific rationale of using this technology to help choose our treatment. And for them, the design was to look at patients with locally advanced or unresectable or metastatic GISTs. And they were planning to treat the patients at that time with sunitinib or regorafenib, essentially for patients who are progressing on imatinib. At the time of progression, they will offer a ctDNA testing. And if there's the presence of the exon 17 or 18 resistant mutations, they'll go straight on to using regorafenib. If it's exon 13, 14, they'll go on to use sunitinib. And at different time points when there's progression, they'll also use ctDNA to help guide the treatment, as opposed to the old pragmatic use of, say, first line, second line, third line, or fourth line. The primary objective of this trial is to determine the effect of ctDNA stratification on response rates in patients with advanced GIST being treated with sunitinib or regorafenib. And their plan is to recruit up to 48 patients, mainly based out of the University of Miami Sylvester Cancer Center, outpatient treatment facilities, inclusive of all their satellite campuses. It would take about 3 years to recruit these patients. Expected treatment duration is about 10 to 12 months, and they'll be following up these patients for about 2 years. It will take some time for this data to be generated, but again, a lot of credit and kudos to the Miami team for setting this up for the GIST community. And I think this will help consolidate the potential position of using this technology to help guide treatment for our patients. And the last trial that I'd like to discuss is the PEAK study. Again, you may be familiar with this particular trial. This is a phase 3 randomized open-label multi-center trial of bezuclastinib and sunitinib in combination with sunitinib in patients with GIST. This particular presentation was presented by Dr. Nita Somaya at the CTOS meeting. And a bit of background again about why there is this potential combination. You would recall that in actual fact, with the different types of tyrosine kinase inhibitors, they do have different selective efficacies on the different mutations. We know that for the first line treatment with imatinib, typically it targets exon 9 and 11, but as there's evidence of resistance during treatment, they lose its effect, and therefore we need to move on to second, third, and potentially fourth line. Now, in the second line setting with sunitinib, we know that we cover 13 and 14 mutations, but there is at least half of the patients when they progress on imatinib actually have a exon 17 or 18 mutation, and this is not covered by sunitinib. But now, bezuclastinib is also a pan-KIT inhibitor, which doesn't have much activity in the 13-14 space, but has activity in the 17-18 space. So the belief is if we combine the two drugs together of sunitinib as well as bezuclastinib, then you have good coverage of essentially all the commonly seen primary and resistant mutations in GIST patients. And the other thing about bezuclastinib is it's a drug that has relatively minimal off-target effects. And what that really means is there's a potential for you to combine this with sunitinib without much additional side effect toxicity profiles. Now, again, the human testing is still just ongoing as we speak. We're gathering this data, but based on the laboratory investigations, the additional toxicities should be minimal. So that makes it a very good candidate to be combined with sunitinib. In a prior phase 1/2 study that was presented and actually published by Dr. Wagner and his colleagues in JAMA Oncology in 2021, we were able to see that the combination of bezuclastinib, at that time it was named PLX9486, together with sunitinib, It led to improvements in the sizes of the GIST tumors in patients, with most of them actually being stable and some of them being shrunken over a long period of time. And you could also see that in the small number of patients that were tested in this early phase clinical trial, that performed better than using the bezuclastinib alone. And this is, again, the waterfall plot, but being presented in a portrait format. And you can see that in the patients who are actually treated with bezuclastinib together with sunitinib, most of the patients actually have stability in their tumor sizes, as well as some shrinkage. And there was one patient who actually had what we call a complete response, where all the tumors actually shrunk. Now, the PEAK study is a next step in terms of the development of this compound, which is a global randomized phase 3 trial looking at the combination of bezuclastinib together with sunitinib. This particular trial is the randomized portion, which was presented as a trial in progress again, where the data is actually not fully available, but the plan was for a one-to-one randomization between the two arms. Now, they were able to present some of the data that was in this particular portion, as well as this portion, the part one. What they have found, at least based on the small number of patients that were within the group, was that the objective response rate is about 20%. And in patients who had prior imatinib treatment, the objective response rate was 33%. We're still gathering data again as we speak in terms of the trial, recruiting patients and generating the data. But out of the patients that they showed, interestingly enough, there were 2 patients who actually had a partial response in their tumors. But this partial response actually occurred quite late in the treatment. So at about 8 cycles after treatment, then the tumor continued to shrink into a situation where it became 30% smaller than its original size. So I think it may take a bit of time before we see some shrinkage in these tumors, but may have some delayed efficacy in some of our patients. Now, in terms of the safety profile, again, these are very small patient numbers, but it does seem as though the majority of the toxicities were of low grade. So, for example, diarrhea, again, happening in 58% of the patients, but only 11% of the patients had a grade 3 diarrhea, and they were documented as being reversible. And it seems as though that these side effects is probably what you would see in patients who are treated with sunitinib alone, and there does not seem to be much additional side effects in the combination. Now, my take on this study is it does seem as though that the safety profile of this combination seems to be quite acceptable and quite similar to patients with monotherapy of just sunitinib. We do need to wait for the efficacy results. It's good to see that this is a very international representation in terms of clinical trial. We ourselves here in Hong Kong is also a study site, together with a lot of sites in the US and North America, Australia, as well as in Europe. So hopefully we'll be able to recruit patients quite quickly and be able to have a readout on this potential treatment of this combination. So to summarize, really, the 4 abstracts in the whole GIST space at CTOS 2023, we know that GIST is a heterogeneous disease. It gives various clinical behaviors, and this is all very dependent on the molecular signatures. We are anticipating readout from practice-changing studies from the ones that I presented, where in the old days, in the unselected paradigm, we would use imatinib, then second-line sunitinib, third-line regorafenib, then ripretinib on a stepwise, very pragmatic format. But nowadays, with the use of ctDNA and potentially identifying the different molecular groups, and we know that the different drugs may have different efficacy in the different groups, we may now start to consider using the drugs in a different sequence based on the molecular profile of our patients. There's a lot of translational research going on, including the use of ctDNA, which could help monitoring, treatment selection, as well as prognostication for our patients and to help support clinical trial decisions. And I think at the end of the day, as with always, the future advancement in GIST management needs to be multinational, such as those international clinical trials I've mentioned, as well as being multidimensional and multidisciplinary. And with this, I would like to end and also a quick shout out to my colleagues who are also on the organizing committee of CTOS 2023. It was a very successful meeting, and we look forward to seeing all of you at CTOS 2024, which would be in San Diego in November next year. And I'll be happy to answer any questions. Apologies for my voice. It's 6:30 in the morning. So this is the early morning voice before it tunes in for clinic.
Okay, amazing. Thank you so much. That was a great presentation, and thank you for waking up so early to do this for us. So people can feel free to ask questions in the Q&A or the chat, whichever works for people. I'm going to just kick it off and ask at the end how you talked about re-challenging the sequence of drugs. There are some patients who might have some primaries of 17 and 18. Is there consideration in terms of considering these drugs in the first line for some of these patients who have primary mutations for 17 or 18?
Yeah, I think that's very reasonable. And I mean, as we understand the drugs a bit more, we know that, for example, imatinib has really no effect on 17 or 18. Now, I think one of the issues would be reimbursement issues, regulatory issues in terms of whether or not we can use these drugs. But from a clinical efficacy point of view, yes, if we have proven primary 17, 18 mutations, there's no reason why we have to go through the hoops and hurdles of imatinib, then sunitinib, and onwards. I would start off with regorafenib if that's available, or potentially ripretinib as well.
Yes, and unfortunately, not everybody got to hear a debate between Dr. Loong and Dr. Jones about regulatory approvals for treatments. That's a whole other topic in itself, but it was an important thing to bring light to in terms of advocacy. So thanks for mentioning that. ctDNA, that's also something that's emerging, and we're glad that you brought up the study that's being done out of Miami. Is this a procedure that should be done on a routine basis for patients, just to sort of monitor, if you're looking for the minimal residual disease or any other new mutations that come up? Should it be done as frequently as we get scans?
I think there are studies ongoing to really consolidate and confirm the position of using ctDNA and how frequent it should be used. And does it, for example, become complementary to scans? Does it trump a scan in terms of detecting whether or not a patient may progress on treatment, etc.? My routine regular practice would be I would use ctDNA whenever I feel that there may be a need to change treatment decisions. So if, for example, I have a scan of a patient where there is evidence of, say, progression, I do try to get a ctDNA test to see whether or not I could detect specific resistant clones, which then help me guide my treatment. I do not right now routinely test ctDNA at regular intervals. I still use the scans as my primary sort of decision-making process. But as the technology evolves, as the sensitivity of these tests increase, as the price of these tests decrease, honestly, it can potentially be more convenient to get a ctDNA test than to go for a scan. And we also know that with scans, with GISTs, sometimes the sizes of the tumors don't change necessarily, but the behavior may have changed. We can certainly consider getting PET scans for everyone, but that again, increased costs, increased radiation exposure. So I think what we're seeing in the next couple of years is we're going to have I think there are different groups looking at ctDNA and how this could be incorporated into the regular monitoring paradigm, as well as the look at minimal residual disease in the adjuvant space. And as we see these results of the trials come out, then we could confirm the position of ctDNA.
Great, thank you. Somebody had asked about, I guess they noticed that maybe some of these studies were done for a younger average age, and there was just curiosity about geriatric considerations for the use of IDRX 42, but maybe even for all the studies in terms of an older population regarding the criteria.
That's a very good point, and I think the older population is always an underserved population in terms of clinical trials. In general, I think if the toxicity profile of the drugs are somewhat acceptable, I think the data that we generate can be placed into this older generation group as well. But at the same time, there are situations when the regulatory authorities do mandate a specific trial looking at older patients. Now, I don't know whether there'll ever be a specific trial looking at, say, the geriatric group. But I think as the trial reads out in terms of the side effect profile, we would be able to then see whether or not the older patients may be able to handle the side effects. Specifically for IDRX, it does seem as though diarrhea is an issue. Now, of course, if you're older, I can potentially see it being more cumbersome for somebody who's older. You can actually lead diarrhea, if severe, can lead to problems, including electrolyte problems, dehydration, and that can actually lead to hospitalization. So it's something that we do need to watch out for. But I don't think there is specifically a geriatric cohort that they've planned right now.
Okay, thank you. There's somebody from the Philippines who wants to know if there's any GIST centers or specialists in the Philippines.
Yeah, I mean, we could talk offline in terms of the GIST specialists. There are a couple of sarcoma specialists who I'm quite familiar with in the Philippines who would treat GIST. I think in Asia, and that's also similar even in Hong Kong, for example, we have oncologists who treat GISTs. There are some surgeons who traditionally have treated GISTs, as well as giving the systemic therapy as well. And there are about, I know about 2 or 3 of them in the Philippines who are quite familiar with the disease. So maybe if Lloyd can email me, and I could probably pass in some names.
I can connect you too. We still have time for questions. If anybody has any other questions to submit in the Q&A feature, I'll give it some time. Otherwise, we could preserve Dr. Loong's voice a little bit longer. Okay, here we go. So the PEAK trial appears to be taking place at a single site here in Australia. I love how we're global here. This is great. Are you aware of any other sites that may be coming online in other states?
That's a very good question. I don't know. I would imagine, and I would presume that in Australia, it's such a big country, they would open various sites. But I think it's a decision that's made by the study sponsor. I think it may be worthwhile just reaching out to the single site, which is actually open, and really ask them. And I'm quite sure they would accept referrals as well from various locations in Australia.
Yeah, and I can circle back with the Cogent team to learn more about that. So ctDNA seems to resonate with people from this from the participant list. So just want to know how widely available is ctDNA? Maybe how would they approach talking to their doctor about it? Like, would there be a certain lab that does it that they need to recommend?
Yeah, so for ctDNA, I would say it's readily available in most places. And when we talk about ctDNA, many a times we're talking about a next generation sequencing profiling service that's being offered commercially. There are several large international companies who are doing it, such as Foundation Medicine, such as Guardant Health, such as Claris. These are the big names. There are also smaller labs as well, some academic institutions looking at ctDNA. I think most of the clinical trials that involve ctDNA uses commercial labs, which are internationally available. They would have different vendors within the different countries. I would say most of the oncologists globally have access to ctDNA now, because the great thing about ctDNA is from a operational perspective in the clinic, all I need to do is draw the 2 vials of blood, put in a special tube, and it gets couriered, DHL, UPS, FedExed out to a central lab somewhere around the world, as long as it gets there within 72 hours. And it actually increases the global reach of a next generation sequencing test to patients who may live in areas which are otherwise do not have a lab of their own or may not be readily accessible. So I would suggest that you talk to your oncologist. They certainly should have access to this particular type of testing. And if so, then discuss whether or not it may be a suitable test for you, and also at what juncture of your treatment journey. It's not necessarily a test that you do regularly. But as I mentioned earlier, for me, I would do it whenever I want to change or consider changing the treatment for a particular patient, because I would like to know whether or not there are specific resistant mechanisms, resistant clones, which may or may not be targetable in the drug that I plan to use for the patient.
And then do tumors with different mutations all shed similarly into the bloodstream?
They don't, and that's one of the issues with ctDNA, because it's indirect. It's dependent on the biology of the tumor as well, whether or not they shed quickly, whether or not they shed or don't shed, at what time point you're taking the blood. So there are nuances with ctDNA, but as the technology also improves, it becomes a bit more sensitive. You require a smaller amount of tumor DNA in the blood for it to be detectable, then the efficacy of the test also increases. So at the end of the day, the gold standard is still considered, tissue testing is still considered gold standard. But on the other hand, if you have various tumors, it is not practical for you to do biopsies in all the different sites. And the ctDNA may give you a good assessment of the different clones that's within your body.
Yeah, thank you for that explanation. There's a gentleman who underwent a total gastrectomy, was placed on imatinib for 3 years, doesn't know the gene mutation because of the unavailability of tests in his country. So what should a patient do when the oncologist just prescribes imatinib without not knowing the mutation behind it? This is the $1 million question, and that's why
This
we
is
have
the $1 million question. Yeah, it's a $1 million question that can be solved with $200, I think. I mean, at the end of the day, I would think in the situation such as this, where you're using adjuvant treatment for 3 years of imatinib, it is very important that we know whether or not you actually have or had a GIST that is sensitive to imatinib. So I think a molecular test is a must. You need to know whether it is exon 11 or not. And, 70% of the chance it is exon 11. So you have a very good chance that it is. But if it isn't, to spend 3 years on a drug which has side effects, the costs involved, the lack of efficacy doesn't warrant the use of the drug. So if there is no access of it in that particular location in the Philippines, I'm quite sure in Manila they do have it. I have colleagues there who would be happy to help you organize this. This, of course, will have to be done through a pathologist, but again, maybe Sarah can help me connect with Lloyd, and then we could see where we could take this forward.
I love the connection that we're making here. That's great. Okay, so I don't see any other questions come in. I'll just give a little bit more of a chance if anybody wants to pop another 1 or 2 in. Obviously, we can stay tuned as we learn more about these trials and ctDNA as it emerges. I'm sure over the course of the next year, more will come, more information and knowledge. But it looks like we can give you guys back some time at the end of the hour. I just want to say thank you to Dr. Loong for his time today. As always, it's just been a pleasure to partner with you to give these overviews of these scientific congresses that take place. Before I go, I just want to do one last pitch. My team has shared with me that I need to give some information about tomorrow, which is Giving Tuesday, which is a really big day for nonprofits, because it's one way that people can give back to the community, of which we do our best to serve you. So I want to remind our listeners that as Giving Tuesday is a day we can come together, show generosity towards organizations we care about. Since foundations and corporations are less likely to fund a rare cancer, the LifeOff Group relies on individual donors to continue our mission. And tomorrow, please consider providing a donation to the LifeOff Group so we can continue to educate and empower our patients. So with that, I just want to say thank you to everybody for your time today, and either enjoy, if you're on the other side of the world, the rest of your day, or on our side of the world in the United States, your evening. So take care, everyone.
Thank you. Bye-bye.
Bye.